separate set of techniques. And again, I will warn you that this is something the state is looking at. So even if you don't do a lot of pediatrics, I know a lot of places maybe do 1 or 2 kids a year. Some places do more. There should be a separate set of exposures with measurements available, publicized, hanging in the rooms. And by the way, each room needs its own chart. You can't just have one for the whole department. So this, again, is a good thing for students to do. We're having our students make up technique charts all this semester, and they're so happy about it. And one thing we're having them do also, and this is useful when you're doing your technique charts, and I can't tell you what a surprise it was to our students and to us. It's a long story as to how it came up, and I'm not just going to talk about MCC. But one of the things that our postgraduate employer surveys said were that our students weren't really strong on techniques. So we asked them about it. We went back and asked some of the employers about it, and then we asked some of our graduates and our current students, and they said, well, what about your AEC techniques, which is what most people use, AEC. I said, what about them? How do we know what they are? They're AEC. We said, the little readout at the end. They go, what readout? They didn't even know that there's a readout. We assume, as educators, that this is just stuff that they're catching out there, and we forget that unless you're told something, maybe you're just not seeing it. So we have a little project that they're doing that they have to record the MAS readout every time they use AEC to kind of get a sense of what an MAS would be for a PA chest or a lateral chest, AP lumbar, anything like that. And that's been effective, so we've been drilling them on it. But one of the things, just going back to technique charts in this kind of dose, is paying attention to what is being used. And that will help you kind of develop your own technique chart in your mind. But having a technique chart publicized is what the new requirement or best practice really is. So I would get on those. This is something I'll talk about a little more in a bit, but the different EI standards, and EI exposure index, I know in some places they're called S values, and some, if you use Siemens equipment, it's called an EXI. I don't even know what that means. Technologists must be familiar with those standards for their pieces of equipment. Does anybody in here not get an index type readout? And an index, it's an exposure index number, an exposure value, whatever it's called. Is anybody working with equipment that doesn't give you that number? Yeah, the reason for that is that's actually something you have to add when you buy your software. And most places have it set up. The hospitals do at least, but I know some of the offices, and this is not picking on offices, but I know some offices didn't buy that part of the software, so they don't have it. Our students go out to some sites that they don't even know what their index number is. The texts just go by how it looks. And so that's another thing that's kind of harmful, because who knows what that number is supposed to be. I mean, the places, and God bless them, it's not their fault, but nobody told them that they should have that number. Well, that's another thing that the state is going to start looking at to make sure that all the equipment out there has that. Like the case when we were going from slow, par, and fast screens to the number system, and all the industry players had different values for their different speeds, they came together with that number system, the 50, 100, 200, 600. That's what they're doing now with this index kind of thing. The industry has come together with the physicists and with all the people who know things like this, and they've developed a system that I'll talk about in a little while. And that's called the deviation index. And I'll explain it a little bit in just a bit. You have to know what your limits are, what the target is. Again, speaking to CareStream, if you're using DR, direct capture with CareStream, the target number is 1,500. And this is all a very fancy measurement of the amount of radiation, so many millirems per something or other. When you're using Kodak CareStream CR numbers, it varies. If you're doing extremities, they want it to be 1,700 to 2,100. If you're using, and I could be backwards on this. If it's for abdomen and chest, they want it to be 1,800 to 2,200, something like that. So there's varying ranges. With a lot of the Siemens equipment I can speak to, they have a range of 1 to 1,000. Nobody even knows what that means. It just seems like a lot. Again, it's the amount of radiation read by the detector in a certain amount of time. What we've done on our campus, and I think this is sort of like what Ann sort of alluded to, we found a range for that. In that range, we said, well, we think you should be around 300, 400 on most of your exposures. because otherwise we're really overexposing. And I don't know, if you ask any of the service reps from Siemens, they'll just say, oh, it's 1 to 1,000. That's a pretty big range, because 1,000 can be very high technique and be very overexposed. So we need to be aware of that, and I'll get to a little bit more of that in just a minute or so, a few minutes. Let's see. One thing about this, when we have not fallen into the range of our exposure index at 1,700 to 2,200 or whatever it would be for your particular piece of equipment, you have to make a decision as to whether or not the image should be repeated. Rule of thumb is if it's underexposed, it should probably be repeated, because you can kind of think of a low number, whatever that means with your system, whether it's a high S number or a low everything else, that stands to reason that that film is underexposed, underpenetrated, underexposed. And that's equivalent, again, thinking back to the olden days, of a light film. So if it's not exposed enough, information is missing, just like it was when you'd get a light film. And we knew if our film was too light, we'd have to take it again. And we'd have to increase our exposure factors to get a decent image. If it's overexposed in whatever system you have, that's like having a dark film. Now, if it's way overexposed, it's like having a really, really dark film where you couldn't see anything. If it's slightly overexposed, that's like when we used a bright light, a big spotlight that we'd shine on our films to see the stuff that maybe was okay to pass, and some doctors were better at that than others as far as accepting that. So tech has to be able to understand when it's necessary to repeat a film if you're not in the correct parameter for that particular system. Some of that will come from your radiologists. When we first started at Rochester General, the image would look fine, and we all know the workstation image always looks worse than the PACS image. And the radiologist would get the film, and it would be repeated 5 times because people were trying to get into that range. And this Dr. Siegel would say, I don't want you doing all these images. This first one was fine, and even though it was a real low index number. Sometimes you get a low index number, the film looks real grainy, and you need to repeat it. But in some cases, the radiologist will say it's okay. So that's something you have to be aware of, and you come together as a department to determine what your standards are. That's always been the case, too. The department has always, the physicians usually, along with management, usually come together to determine what constitutes a good image. That old H&D curve kind of thing, and that's what they are supposed to help you with. So, the next best practice. Recognizing image artifacts. The interesting thing is, some artifacts are just easily recognizable. We know a fat roll when we see one. We know if there's a medal on or a key in a pocket or something like that. But with our electronic imaging, and particularly, again, with the CR, there are things that show up on our images sometimes that are just funky looking, that aren't really something we're familiar with or we're used to seeing. We all know, again, those of us of a certain age know when a film has processor scratches on it or roller marks. We know what that looks like. But when you get a CR artifact, it can often look like something very weird on our film. Sometimes if there's a little piece of the rubber bumper things on the readers or some part of that mechanism that gets into the actual slot where the screen falls into, it will show up as like a big white blob across the middle of the film. And sometimes you can't even see it up close. When we had this problem at my clinic site, and I could see it from across, but if I got closer, I couldn't see it on the film. It was very, very weird. And yet the radiologists were noting that there was this big white artifact right in the middle of this particular image of 14 by 17 images. And we looked at the cassettes or the imaging plates, and we looked at everything. It turned out it was artifact and debris in the actual slot of the reader. So we knew then that when we start seeing that artifact, you had to go in and clean that out. And of course, the screens should be cleaned on a regular basis on the CR cassettes, just like they are with our film screens. Some of the other artifacts will occur when the software isn't working correctly. Now, we select our algorithms based on our position and the part being imaged. Sometimes if you just select the wrong algorithm, it'll put an artifact on there because the software isn't reading it quite right. So we as technologists have to kind of be able to recognize what it is that's creating that artifact and make sure that it's really something that is either a technical thing or something with the patient. kind of something we have to use. I'll tell you one area of electronic and digital imaging that is very understood at this point, for lack of a better word, is the quality assurance aspect. We all know that they can go in and look at our repeat rejects. They can look at the reasons that we repeat a film. Does anybody even repeat films with electronic? It just doesn't seem like it. Everybody just accepts everything, and that way you don't have a repeat reject rate. What they do at my clinic site is randomly, once every week or 10 days, they go in and pull up certain texts and look at their index numbers. They look at their positioning. They pull up cases. And they look at the time of the procedure. Anybody else have that going on? It's really awful. They have this quality assurance guy who's sitting there monitoring it. The administrator of the department, nice guy, but he came from Carestream Kodak, and he was the quality assurance director or something, so he's into all that sort of thing. So the techs are under a great deal of pressure to get it done, which is not really good for the patient. It's terrible for us as educators because they don't let our students do anything. And we're not really sure if they're doing things the right way because of those high index numbers. But anyways, it's happening, and it's happening in a lot of other places. So you have to make sure you select the correct algorithms. Every choice you make is an algorithm, and you can. Some people like to play around, and if the film doesn't look quite right on the workstation, maybe they'll reprocess it as something else, like a hip as a chest or a chest as a hip or something like that. Well, that does a couple of things, but the worst thing that it does in most systems is it will put that name on the report. So if you do a hip and you process it as a chest, and it comes up in your DICOM or on your report, it will say PA chest, even though it's an AP hip. So you have to be very careful, and you're not supposed to do that. That's not a best practice. So we're supposed to be electronically recording our exposure techniques. Many systems don't do that. Even again, I will talk about our lab and my clinic site. Our DR does it, our CR does not. It comes up when you first do it, but as soon as you save it to the PACS, one has it and one doesn't. The best practice would be to have all that data recorded, your MAS, your KV, your exposure index, put it into the DICOM header so that everybody knows. Now, a comparison is years and years ago, again, when mammography first became dedicated equipment. That's how old I am. There was no dedicated mammo equipment specifically when I was first in the field. But when it first came out, the way we used to determine what to use on patients was based on previous studies. So if you had a patient who had large adipose-type breasts, they'd write that technique down. And if you had a patient with large adipose breasts, that's the technique you'd use. And that's sort of the concept here until you developed a system. If you know that this works on this kind of patient, under these circumstances, this is a technique you can use. Or if that patient comes in again, that you can look up what the previous technique was that worked. Now, I don't know about any of you, but my experience with both CR and DR is that you can do the same study, position exactly the same, 5 times in a row with the same thickness part, position everything the same, and get 5 different exposure index numbers. Who can explain that? I can't. And every single possible thing is exactly the same. And how do you explain that to a student? I can't. And what do the software application people say? Well, but you're close, you're in range. Not the point. The point is we're trying to teach these people something concrete, and if we don't even get it, how can they? Yeah, exactly. So it's an interesting thing. But at any rate, maybe recording the dose on each image will be helpful. 16, a comprehensive quality assurance program. I mean, that's something that everybody's working on at the moment. Every system has its own type of quality assurance tool that means different things. If you look in some of the books, they all kind of look the same. The biggest quality assurance testing that's going on is for the workstation screens and the PACS screens, the monitors, instead of any other part of it. I mean, the usual stuff, the tube filtration and all that, that's all still being done the same. But the actual image is really up in the air right now for lots of things. I will tell you this, mammo facilities, if you have electronic imaging, full field DR, however you're doing it, they are dinging places if you're not running a film, laser film every day through the printout, even if you're not printing them out. That's something they want to see. It's like they don't even know what to do, so they're just saying, well, let's do that one. If it's being saved to PACS, they want to know that your printer is still working. So I can tell you that some places have gotten cited for that. So this is a big one, and it should be 17, really. Development of a collaborative and supportive work team in which members learn from one another and practice radiography safely and ethically. When we try to correct people, or we're trying to tell you and teach you how to use it, people shouldn't get mad at us. It should be something that, like, oh, God, thanks, I didn't know that. Like, I know when I mentioned the speeds before, a lot of you were writing, and that happens every single time I do this talk. People aren't even aware that speeds are different with these different systems. And quite honestly, even though most DR acts like 400 speed, there could be some that are different, faster, slower, who knows. The Siemens one in our lab is very, very sensitive to every little change. So, you know, we just assume it's like a 400. But one thing that is really missing from what used to be is that collaboration between the radiologist and the technologist. I learned everything I know from radiologists either embarrassing me or just telling me, or even the residents when I worked nights. Before I became a full-time teacher, I worked nights, evenings, weekends for 12 years. And I worked with those residents, and everything I know about stuff I got from them. And I told you about the one who came and did that lecture last week in my pathology class. I mean, I even learned something from him last week, because I mean, they have a whole different perspective than we do. They tell you what you need to see on your film. What are we really looking for? I can't tell you how many times I cut the top of a lateral decubitus abdomen because I wanted the spine centered. Nobody ever told me that they wanted the top on. I mean, talk about missing the point. And there's no collaboration like that now. And part of the problem is, even if you did see the doctors, they're not really even sure. You know, they just know how to work those packs and to manipulate their images, and however you get there, they're okay with. But even that post-processing collimation, I told you that one group in Buffalo wants the techs to do it. That has to be because they just don't know the implications of that. And you know, as far as technique goes, radiologists don't really learn it exactly the way we do. Again, back in the day, when I was first out of school, the first radiologist I worked for, I always said he was like one of the original radiologists, because this was in the 70s, and he was about 70, and let's see, he discovered X-rays when, so I figured they were right about the same time. He taught me so much about technique and why we did the things we did. You know, stuff that you just miss as a student. And then when you'd work with a radiologist, they would say, well, this is good positioning, that's not good positioning. Well, now they don't see you at all, most of the time. I mean, sometimes they do, but in a lot of the bigger hospitals, it's just sent to PACS, and you don't see them. And this doctor the other day, I always ask this question every year because I want my sophomores to hear this. I say, do you guys know who the good techs are and who the bad techs are? And he goes, oh yeah. He says, after a while. And nowadays, you know, we used to be able to hide behind numbers or initials or something, and now your name comes right up on the images, right? And he said, oh yeah, we know who they are. And he said, I said, why don't you ever do anything about it? And he goes, well, again, you know, I'm a resident. I can't do anything. But people get reputations. When you pull up reports, and this happens with me a lot because we do our film critiques where we just pull up random studies and they'll talk about them, I can't tell you how many times it'll say suboptimal images, suboptimal quality. Cannot be determined due to underexposure, overexposure. You know, name the thing, but they're hedging because they don't want to put their name on something and be uncertain. So these are things that if we worked better with them like we used to, you might not have these problems. And everybody should be teaching each other, so this whole collimation thing, the post-processing cropping, should be something that's out there being discussed, and the use of markers and all that kind of thing. And then learning from each other. Yeah, hopefully people hear techs and students. Now, students don't go and say, well, on Saturday, Paulette and Ann said, you should do it this way, because they're not going to take that well. But you know, if you say, well, gee, you know, we had this interesting thing on Saturday, but techs should go back and try to teach each other and not be mad. It's nobody's fault that nobody's doing it right. And I'll tell you this other little thing. I told you that everybody in that room had the same story, even though we were from all over the country. 80 MAS at 80 kV. Everybody said that that's what all the people were using. I hope you don't have to raise your hand, but that's not appropriate for every image. A thumb doesn't need 80 MAS at 80 kV. But someone started that, probably application specialists or the software sales people or something, said, well, you want a good, consistent, steady kV, 80 kV. You know, there's a lot of literature in our field, in our textbooks, say 80 kV is like the kV that will get everything. But you don't need that for everything. Just like, by the way, you don't need a grid when you're doing hands and fingers and wrists. And a lot of the DR units, the grid is always there unless you take it off. Some of them set up automatically, like you go in and you pick the right picture and then your technique comes up. Make sure that there's no grid on there. Sometimes it is and sometimes it isn't. Again, every system being so different, that may be the case. These are things that we should be learning from each other and not get mad at each other when we say it. Because you got to be polite. You know me, I'm real blunt, like, what are you doing? But I only say that to people I taught. So some of the technical, just to review, I know you heard a lot about KV this morning and the development of technique charts. The technical factors and their impact on DR and CR are, as I said earlier, the exact same kind of thing that happened with film screen. 15% rule used to be considered mainly a density maintenance formula. Like if you needed to change your time or your contrast or something, you would use the 15% rule. Now, 15% is the amount of KV change that you can make to assure that you're getting a higher KV on a lot of your studies. Sometimes it's just not practical if you're doing a very small part or something like that. But as you're developing technique charts, you can apply that 15% rule that I saw in Anne's notes. She already told you about, so I won't repeat it. But it's a very useful tool. And it doesn't mean you necessarily always have to do exactly 15%. And the old rule of thumb was 10 kV, because that's about 15% when you're talking about many of the KVs, and 1 or 2 kV won't make that much of a difference. MAS impacts our exposure number, and it impacts our dose, but it's no longer a density factor. We don't call it density on electronic imaging. We call it brightness. MAS may affect the amount of radiation the amount of index number that you're getting, but really, as I said earlier, it's the KV that's really doing it. But a good little rule of thumb, and this may work with other systems, but I can tell you with absolute certainty that if you're using CareStream software, that doubling or halving the MAS causes a change of 300 points, and that's excessively reliable. It happens. We've not been able to disprove it in anything that we do. Again, I have it in my lab, and I have it in my clinic, and we have it in all our clinics. But that may be something that you can take and try with whatever system you're using to see. So if you're 300 points low and you just need 300 points to get back, you can just double your MAS and vice versa. That's a handy little tidbit. Let's see, what else did I want to say about that? Anything? Other technical factors that impact our DR and CR, and most of this is based on our experimentations and our use in the clinic. Reciprocity law, all you students should know what that means. It means any combination of MA and time, as long as it equals the same MAS, will give you consistent results, similar densities. Well, we don't talk about density anymore, but your index numbers will come out, your exposure values, whatever you call them, will come out roughly the same. Again, you might be 10 or 20 points off, but you're still in range. And I guess that's what we shoot for now. We don't shoot for exacts, we shoot for ranges. So it's good to know that reciprocity can work. And that's useful if you have motion problems or things like that. Which, incidentally, motion, speaking of which, randomly pulling up studies at the hospital, I am astonished at how much motion you see on images now. Because you can see on those little itty-bitty workstations. Who can see the motion? Nobody can. And the radiologists, again, they're not saying anything about it. They're not right there to say this film is full of motion. That's unfortunate. SID. I had a very ambitious student this year. I mean, really, these people must have time on their hands. But we do an SID lab, a density maintenance lab, or dose maintenance, whatever we call it, inverse square law lab. And we change our distances, and we see what the effect is on our index numbers, our exposure range. And he figured out that the percentage of distance change was roughly equivalent to the change in your index number. So your SID is very important. One thing that always happens, has always happened, continues to happen, is when people go, say, from a tabletop study into the Bucky, they forget to change their distance to go from 40 inches or whatever the distance is, 72. And not doing that will affect your index number. So that's an important thing to know. Our filtration changes. If you change filtration, add or detract, we don't do that very much. Like some units still have the dial that you can change the filtration, but I know we don't. That does also change your exposure value. When all of this first was being introduced, and in particular the CR and DR, I think every lecture I went to talked about how centering is going to have a big impact on your index number, your outcome image. And that's because of the design of the technology. If you don't know, you probably do. The DR, the direct capture unit, it's like a little series of switches. There's all those lots and lots of rows of switches and going in 2 directions, and each switch turns on and off as the radiation is being reached, the correct radiation amount is being reached. With the CR image, it's all created on that screen, and it drops into the reader, and the laser scanner scans it. And we were told that because of the way the design was, that where you centered and how much you collimated was going to make a difference in your outcome. And that may be true. It doesn't really affect the DR at all that much, according to our experimentations and our research. The CR, a little bit. You'll get a little bit of a change. If you're off center with your centering on a CR cassette, you might get a difference in exposure index number. But again, if you're doing the same thing 5 times in a row, centering the same, you might get a difference. So it's not that significant a thing. Partitioning, and how you can divide a cassette in half, I don't think anybody's doing that anymore. But if you are, even that doesn't change your value. Your numbers are coming out pretty much the same. What does influence your index number is the size of your image receptor plate. So if you're using CR and you use a 10 by 12 on something like a finger, you're going to get a much different readout than if you're using an 8 by 10 on a finger. So you should use the smallest image receptor size possible. And actually, that was supposed to be in our paper, and it never made it. It's not exactly said that. It probably is in the full version, but it's not in those recommendations. The size of your imaging plate does matter. So you should always use the smallest size possible for the part that you're doing, which, by the way, was always the rule. It's always been the case. And then use the image receptor the way the part is. If it's wider than it is long, use the film, what do we call that, landscape? I still call it transverse. If the part is longer than it is wide, use it portrait or lengthwise. And then collimate accordingly. Collimate down to the size of your part. Again, state likes 1/4 inch all the way around, but more is better when it comes to collimation. Unless you're collimating off, we don't want to do that either. So I did want to talk a little bit about the deviation index because I know it's a new concept. Does anybody have a unit that has a DI or deviation index on it? Okay. As of 2012, it's becoming required on all new processing software. Here's one of the confusing things. When we change our processing, all we're doing is changing software. I mean, we used to think of it as changing films and all that. Now all we're doing is changing the algorithm sensitivity and the ranges and all of that kind of thing. The industry came together in 2010, 2011, and that's where we got some of the information for our paper, and came up with this deviation index. So it's apparently something that can be added to existing software, but you pay for it. Some upgrade of some sort. But all new software installations from 2012 on supposedly is supposed to have this value. So the formula is the deviation index is equal to the 10 log 10 of the EI over the EIT. Who knows what that means? We don't have to. What we need to know is what the outcome should be. And a value of 0 means the proper exposure is achieved. And again, this is consistent. This is taking into account all the systems. Whether it's Fuji, Philips, Toshiba, who else? GE. Who else do we have out there? Carestream, Siemens, all of them. They came together. They all came up with this brand. They figured it out using that formula. 0 means you're in the target range, your proper exposure. Negative number means underexposure. Positive number means overexposure. So it's something a little bit like our density values on our AEC. I'll just tell you one sec. I see people writing. I have to wait a second. And actually, I found this information online. I got this specific information from one of the articles. I just put in deviation index, radiographic imaging, blah, blah, blah. And some of these articles came up, and this was a good one. And I'm pretty sure we used this as one of our references for the paper. But this is important. This is good to know. I think that's very valuable information. +1 indicates an overexposure of about 25%. -1, underexposure of about 20%. This is the current set of standards. It's being worked on. They have to go through and figure out the AEC values because we know that that number is going to be different for different sets of circumstances. Just going back to AEC for 1 second while some people are jotting this down. If you are a teacher and all of you who are technologists and have students in your department are teachers, whether you work for a college or not, or a hospital program or whoever, keep in mind that you're teaching blank slates who don't, because we all are guilty of it. You know, we know it, we've been doing it a long time, so we just make assumptions on things, and they just don't have that kind of knowledge that we think they have. So point things out like their MAS readout. Now, some places I know, like when we used to do barium enemas with lateral decubes, I know we'd say for the PA or the AP, oh, look at your MAS readout and use that for your decube. So then people did pay attention. But when we're using some of these automatic values, the falling load generators, the AEC, the texts are going so fast, and it's only there for a second, a half second, that readout. So you have to be real quick, and that has been one of our problems. But just take a look at that and see what those MASs are. You'll notice that PA chest after PA chest after PA chest will probably have a certain sort of range of MAS readouts. Lateral chests will have a certain range. And that's where you base your judgments on for when you don't have AEC. And that's what, as I said, that's what we have our students doing now, because excessively weak on technique and speeds and things like that. So the DI index being worked on. So what does this all mean? Best practices mean the way we're supposed to be doing things. It's the way the profession, the industry, has come together to determine what is the right way for technologists to be performing their duties. We have something called the practice standards. And just to clarify what the practice standards are and put it in simple terms, if you were being sued, this is where the lawyers would go to look for the things that you're supposed to do. So these are found on the ASRT website, same website I had up before. It's pretty clear. You find it says standards and regulations, and you look under there, and it will say practice standards. There's one for MRI, there's one for CT, there's one for ultrasound and mammography and diagnostic imaging. This past year, the Practice Standards Council Subcommittee on Radiography redid these to update them to reflect some of these best practices and some of the electronic imaging things that are going on. I happen to have been appointed to that task force. You see, once you know somebody on the board, you start getting appointed to everything. I was on 3 task forces last year. It's just amazing. But it was an interesting process because we changed a lot of wording to strengthen our role as practitioners, as technologists, and to make us look less like doobies than people who are in charge of the process, in charge of the procedure. And if you go to, it's like 78 pages long, and it talks about quality assurance and performance of the study and assessment. There's 5 or 6 areas. I'm not going to get into all of that. But these are some of them. This is our scope of practice. These are in our standards. The scope of practice is also found in the practice standards. It's been updated. It will be updated again, so don't commit any of this to memory, because at the next House of Delegates in June, we're going to be voting on some changes. But if you look at our scope of practice, just our scope of practice, which is telling us exactly what we can and can't do, relaying and getting that documentation correct. So that very first best practice is in our scope of practice, even as it is today. Corroborating patients' clinical history with the procedure. We're supposed to be looking at that requisition and seeing, and we do this. It's the right hand that hurts, that we're x-raying the right hand, and that sort of thing. Verifying any informed consents that might come up, and assuming responsibility for patients' needs during procedures. I can't tell you how much of that has fallen off with all this speed, 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 speed. And just speaking of that quickly, to backtracking a bit, one of the articles, or some of the articles that we researched, talked about the value of electronic imaging, and that you can get so much more work done in much less time, so you need much less staff. And in an era where jobs are already hard to come by, that could be a problem. These are all some of the other scopes of practices things, and we're evaluating our images for technical quality. That's going to be changed, but that includes our markers, our collimation, our proper identification, and that would include your index number. Identifying and managing emergency situations, providing education to the patient, preparing for procedures, ALARA principles, again, collimation, using shielding, using proper exposure factors, not 80 at 80 on everything, and all those things. And I couldn't get my font to go down to the right size here. So monitoring students, healthcare providers, ongoing quality assurance activities, and then this is other stuff that's specific to the radiographer. Determining radiographic exposure factors. The point here is, and the reason I put this in, nowhere does it say determine what anatomy is good enough for the radiologist. So this cropping, this post-processing masking is like my big pet peeve, and it's a big issue, and it's not in our scope of practice to determine what the radiologist should and shouldn't see. So again, if I take anything away from here, use your marker and don't crop, and tell people not to do it. So these are some recommendations that we made based on our study and the research, and we talked about all of it. The vendors and industry need to continue to standardize those exposure values, which they're doing with that DI. They should be clearly displayed, made part of the DICOM heading, and really should be made clearly available in the departments on the equipment so people know. And by the way, and I don't think it says it anywhere in here, that exposure readout that you get, whatever it is, your index number, EXI, whatever, is not a dose to the patient. That is strictly the amount of radiation that the detector is picking up. It's a measurement of, it's sort of like one of your meters. So if you say to the patient, oh, what's my dose? You can't really use that. It's not really the same thing, just to make that clear. Technique charts developed and posted and should include those indicator values. Calipers should be in the rooms. All members of the radiology team should collaborate, teach and learn from each other. Grid construction should be reviewed, 15% rule. And text and application specialists should collaborate. It's interesting, because I'm in Rochester, and one of my students was on the CareStream DR software development team. And that piqued his interest in radiology, so he came into our program so he could see what he was talking about. Can you imagine? He's developing all our software, all those little pictures. For those of you who have CareStream, you know, you pull up an abdomen or something, and all the pictures come up of the torso, and you just pick the right one. He developed all of that, but he didn't know anything about what it all meant. And it really opened his eyes when he came into the program. But I'll tell you, he's been a fabulous resource for me. A lot of what I know is because of him. And I learned a lot of the differences between the DR and CR kind of thing. That kind of collaboration could be very useful. You know, they never ask the techs. They always say, go to the people who use the stuff and get the best information. And hopefully they will in the future. And then, of course, the specific protocols for pediatrics, because that is all the buzz in the field now. So if you had any questions, I mean, that's it for me. I think I've done plenty, and I've gotten right on schedule. If there's any questions, you've been digitized to death. Yeah? It does. And magnification will change. And in fact, that's one of the things that my little resident talked about in my class last Thursday, about how they really, really appreciate if you're changing the distance that you note it somewhere. You know, remember, we used to be able to write it on the requisition, like unable to get 72, so used 58. So they know in their head if it's an enlarged heart or the heart is small or whatever. If something like that changes, just note it. But it does change definitely the size if you increase your distance. Yeah, Ann?
Not going shorter in SID, but increasing the SID longer.
Yeah.
72 inches puts your heart at supposedly true to life size.
Right.
And if you go further than that, yes, you're going to shrink it, but just like, you're not shrinking, I'm sorry, you're reducing magnification further. But like Paulette said, you would write your SID on that image. When I do a portable,
yeah,
and I use 80 inches instead of 72, I write 80-inch SID on there to clarify that. No. Sometimes you can't get closer. Right.
Right.
Absolutely not. I've never even heard a peep, but like she said, we don't hear a peep when our films are crap anyway. So,
well, and the other thing is,
it's hard to tell if it's making an impact, but if you look at those two, 72 to 80, the size of the structures is not that significant. It's just enough that we're not cutting it right at the ribs anymore. We've got a little tissue on both sides.
And they do measure the distance from the ribs to the heart, so they can still use that as a guideline. And by the way, in case anybody's interested, the size of the heart, you know who determined that? Insurance companies years ago. How big a heart should be, because years ago we used to take height and weight on patients, so if there was a large heart. Right. Yeah. Somebody else?
Yeah, I wanted to add how important the markers were to back you up. This is years ago with the old Kodak flashing cassettes. I was chief tech. One of our troubled ER patients that was well known was taking the hospital's ER to court over some bad care or something. somehow radiology, probably the lawyers when they were pulling stuff, picked on radiology and picked up the left marker for ribs being right in the middle and maybe barely to the right. So that was an issue that we took care of, but they called the head radiologist in the court, and what happened, the guy asked him about, you know, how can you tell it's left ribs and so goes on. Next thing that happens, the doctor says, well, it's a Kodak cassette, and I know the techs do it this way. The lawyer must be brushing up on, or have experts. Says, what happens if the patient's head's down that end of the table?
Yeah.
So, you know, there was a problem with the marker being in the middle, a little on the right, but also he can't be having it on there. And I on occasion do left ribs with them closest to me too, but make sure that you have the left marker on there. And you can't beat the left, as you know.
Right, and I know there are places where they don't even use markers at all, and they just add the, I don't know how they know, but I'm telling you, document, 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 because if you are going into court, you better be able to prove what you're doing. And the first thing they're going to look at is that scope and standards of practice, and it says stuff about marking things appropriately.
Exactly, and that's what he was searching for, a break in the scope of practice.
Right, that's exactly what they do. And if you can't do something, as we just said with the SID, we used to be able to write it easily on a requisition. Now you have to put it into tech notes. And one of the things that our advisory committee, they come and advise our program on things, and they're all the managers from all the hospitals. They complain every year about our students' lack of tech notes. Well, you know, the tech is there with them. They're supposed to be doing it. So we've been pushing that with our students too. But if you can't do something, or if there's something you want the radiologist to know, put it in tech notes, but put it carefully. Put it in medical terminology so it's nothing that can come back and bite you. We don't have any mechanism. I used to write things to the radiologist on a separate sheet of paper, and I'd say, discard after you read this. We can't do that anymore if you're not seeing them. So make sure you document it properly in the tech notes, any of those changes. And if there's a reason you don't do something, for, you know, or have to redo something or anything like that. I hope this was interesting. None of you were really yawning that much. That's pretty good. So thank you for everything. Merci. I don't know how we get this off of here. Is he going to come and do it? Or is it just gone? Maybe he just took it off. I don't know. Thank you. Oh, you're very welcome.
Okay, very good. Once again, I would like to thank everyone for coming today. We just have a few things here that we need to wrap up before we let you out into the beautiful sunny day.
It's one of those live mic things.
Cindy is going to come up and assist me with this. In your folders that you received when you first came in and registered, there is an evaluation form. We need you to actually fill that out and hand it in to the student volunteers out at the desk. Okay. And if it's a student that's filling it out, please just mark it with an S so that we can differentiate between the two. You will hand them in to the desk as you're leaving, and they will actually give you your CE certificate when you're leaving. And as you're filling those forms out, we actually would like to remind you that your registration fee today bought you a door prize ticket. It's in your name tag, if you want to pull those out. We're going to have a winner here for Kindle Fire.
Does everybody have their raffle ticket out for the Kindle Fire? I wish I was one of them.
Okay, the number is 451538.
Come get it.
Very good.
Thank you, everyone, for coming. And I just want to thank Hudson Valley staff and students for the collaboration. How great is that? And thank you all for coming.